Good afternoon. I call to order the Assembly Health Committee meeting of Tuesday, May 12th. Welcome. Thank you all for being here today. A couple of quick announcements. Regarding time limits, we're going to hear 2 witnesses per side with a time limit of 3 minutes each. Additional witnesses will be asked to state only their name and organization for the record, as well as their position on the measure. For item 3, AB 1357, Mr. Bloom, I'm allowing witnesses up to 8 minutes each for each side. Both proponents and opponents will have the same amount of time. We have on the consent calendar, or proposed for the consent calendar, item number 1, AB 658, Mr. Wilk. Call the roll. Noticing a quorum, Madam Secretary, please call the roll.
Bonta?
Here.
Mainshine?
Here.
Bonilla? Burke? Here. Chavez? Here. Chu? Gomez? Gonzalez? Present. Hernandez? Lackey?
Here.
Nazarian? Patterson? Ridley Thomas?
Present.
Rodriguez?
Here.
Santiago? Steinnorth?
Here.
Thurmond? Waldron? Here. Wood? Okay, we have it.
We have a motion and a second for the consent calendar. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine?
Aye.
Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Chavez? Chu? Gomez? Gonzalez? Aye. Gonzalez, aye. Hernandez? Lackey? Aye. Lackey, aye. Nazarian? Patterson? Ridley Thomas?
Aye.
Ridley Thomas, aye. Rodriguez?
Aye.
Rodriguez, aye. Santiago? Steinnorth? Aye. Steinnorth, aye. Thurmond? Waldron? Aye. Waldron, aye. Wood? Aye. Wood, aye. 11-0.
Consent calendar passes 11-0. I see Assemblymember O'Donnell here. Let's go to item number 2, AB 1223, Assemblymember O'Donnell.
Good afternoon, Mr. Chair. Are you ready?
Whenever you're ready.
I shall proceed. Good afternoon, Mr. Chair and committee members. Today I'm presenting AB 1223, which seeks to take the first step in addressing ambulance patient offload time, or wall time, at hospital emergency departments by defining the term and creating a standard for measuring and reporting. Wall time can be defined as the amount of time it takes from when an ambulance patient arrives in the emergency department to when they are in a hospital bed in the emergency room. Author's statement, excuse me, I'm reading too much here. This bill comes out of my experience. You got me.
I think the bill's been moved and seconded.
That won't happen again. But this bill comes out of my own experience as a Long Beach City Council member, where we dealt with this issue in our own city. And what was happening was our paramedics would respond to a scene, take a patient to a hospital, and sometimes would be tied up for as much as 5 hours, leaning against a wall with a patient, waiting to get an emergency bed available. So what we're seeking to do with this bill is work with the stakeholders and find a solution. With that, I have a couple of witnesses here, Mr. Chair, if they may proceed.
Please proceed.
Good afternoon, Mr. Chair, members of the committee. My name is Tracy Hansen. I'm the fire chief with the Cosumnes Fire Department here in Sacramento County, and I also serve as the president of the California Fire Chiefs Association. I'm joined today by my colleague Ted Peterson from Novato Fire Protection District, and also an active member with Cal Chiefs. We're noting that more and more people are using the emergency department as a gateway to their health care, resulting in overcrowding and delaying of offloading patients, as has been shared already. This delay decreases the number of ambulance units that are available to respond to subsequent emergencies, and also creates a burden on fire engines and trucks that remain on scene awaiting the ambulance arrival due to those response time delays. That also keeps those engines and trucks out of service for fire-related emergencies as well. The backing up of resources is not a result of ambulance traffic. It is due to the hospitals being unable to process patients fast enough on their side of the system. This offload waiting time, dubbed as wall time or ambulance patient offload delay, is a regional problem, and it affects each system slightly differently. What may be acceptable wall time in one region is not in another. Some regions have reported wall times that exceed several hours, and some as short as 30 or 40 minutes, and in each case, those can be very extreme and significant.
This loss of production in both the private and public sector comes at a great cost. The private sector ambulances will have to increase their costs by increasing their staffing, and the public sector costs are burdened by the local taxpayers. Several fire agencies across the state, including those in Los Angeles, Sacramento, and San Francisco, have studied this loss of production in the tune of millions of dollars per year. Many ambulance providers across the state are penalized by fees for delayed and response times, which also can cost hundreds of thousands of dollars. This bill requires standard methodology for calculating wall times, but allows the local EMS system to establish what constitutes acceptable wall times in their area. For this reason, the California Fire Chiefs Association supports 1223, urges an aye vote. Thank you for your time in allowing us to speak on this matter.
Thank you. Additional witnesses in support?
Chris McKaylee on behalf of the California Ambulance Association. The private sector has the same concerns as outlined by the public sector. We've had instances as long as 4 hours, which obviously takes rigs and our EMTs and paramedics out of the system while they wait impatiently. So we urge your support. Thank you.
Additional witnesses in support?
Johan Claes, representing Paramedics Plus, Alameda County's 911 EMS ambulance provider. Support.
Mr. Chair and members, excuse me, Connie Delgado with the California Hospital Association. We actually have a letter of concern on file. We wanted to note that there is a pilot program going on in 5 counties looking at this issue. We appreciate the Assemblyman and his staff effort to address this issue. We look forward to continuing discussions as that pilot is concluded and information can be gathered. So for those reasons, we do have concerns.
Thank you. Witnesses in opposition or in between?
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. We previously had an opposed position, but based on the amendments in the May 5th version, we have removed that opposition. Thank you.
Thank you. Additional witnesses in opposition or in between?
In between, Mr. Chair and members, Jolena Voris on behalf of the Urban Counties Caucus. We have removed our opposition to the recent May 5th amendments. Appreciate the author's willingness to look at our concerns. Thank you.
Witnesses in opposition? Seeing none, questions or comments from committee members? Yes, Assemblymember Rodriguez.
I want to thank the author for bringing this very important bill forward. You talk about the 4 to 5 hours, where I've waited up to 10 hours in a hospital waiting room as we waited for beds to become available or staff to attend us because of, you hit it on the nail, I mean, wall time is huge throughout the whole state. I've been in several hospitals. Obviously, primarily, I've worked in the San Gabriel Valley in Southern California, and just about every hospital you go to, I mean, you're going to be waiting. Just like you said, it's got more busier now with the Affordable Care Act. There's more people that have access to insurance, and because of that, they may not know the difference between going to the emergency room or to a doctor's office, clinic, whatnot. Their first input to seeing health care is by going to the emergency room, which is the most expensive form of medical care. But I just had one question. As we're looking for times, would the time start at the time you arrive, or would the time you go inside the facility, where you would start the clock to see what would be a time that we should be putting on waiting? Would anybody address that?
Well, right now I believe it would start when you enter the facility, but we continue to work with the stakeholders on this bill to further define what the start time would be. So again, we're working with all the stakeholders to get the best definition possible.
Okay. And then, well, just coming from my experience on there, I think by the time you arrive there, even though you haven't entered the facility, because I tell you what, even though when you go inside the facility, it's going to take a few minutes before somebody gets to you. And when they do, they're going to tell you, you know what, I'm busy right now. Why don't you just wait there against the wall, I'll get back to you, and I get back to you. And that could be a half hour, hour. So that's why I say that if you're asking me, because I've been in this industry for over 30 years, I would think 30 minutes is probably the longest anybody should wait anywhere in the state of California. whether you're in Southern California or Northern California, because the resources that are being tied up as you're waiting in those hospitals. I mean, all you're doing is delaying emergency medical care to the next victim out there, the next accident. So just from my experience, I think 30 minutes would probably be the longest anybody should be waiting in the ER, and the time should start by the time you arrive, because like I said, even though you enter that facility, I can tell you stories over stories where they'll just make you wait. And like I said, that can be up to an hour or so. In my case, over 8 hours I've waited. And that's, that's something that we should not be tolerating for our people here in California. So with that, I urge an aye vote. I thank the author for bringing this bill forward, and hopefully we can address this sooner, not later. Thank you.
And thank you for the input, because I know you're much more an expert in the area than I.
Assemblymember Waldron.
Thank you, Mr. Chair. Having come from local government, response times was always an issue, and the fact that, as you mentioned, people are calling 911 when it's not really an emergency, but they can't always tell over the phone if they should just send out ALS versus BLS service, so we always had to send an engine company, and that took people and apparatus out of the system. And there were many times, even in a city the size of my city, 140,000, where all of our ambulances were out, and we'd have to call in for support, from the neighboring city just to do basic 911 response. So I like, where you're going with this. I support it, and also the option of delivering patients to alternative locations, because once you get out on the scene, you can tell, oh gosh, is it, someone had a stroke or they're having a heart attack, breathing, versus, getting a fishing hook in their finger type of thing that could be treated differently. So I like to see where you're going with it, and I'll be supporting it.
Thank you.
Additional member comments? Seeing none, we have a motion. We have a second. Motion is due pass to appropriations. Would you like to close? Assemblymember O'Donnell.
Respectfully ask for an aye vote.
Thank you, Madam Secretary. Please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Chavez? Chu? Chu, aye. Gomez? Gonzalez? Gonzalez, aye. Hernandez? Lackey? Lackey, aye. Nazarian? Patterson? Patterson, aye. Ridley Thomas? Ridley Thomas, aye. Rodriguez?
Aye.
Rodriguez, aye. Santiago? Stein North? Stein North, aye. Thurman? Thurman, aye. Waldron? Waldron, aye. Wood? Wood, aye.
Your bill passes 15-0.
Thank you, Mr. Chair.
Thank you, Assemblymember. Next, we have item number 3, AB 1357, Assemblymember Bloom. Whenever you're ready, Mr. Bloom.
Thank you. Good afternoon, Mr. Chair and members. Let me begin by accepting staff's technical amendments and letting you know that I understand that those are going to be taken in the next committee. Diabetes is an epidemic. I ask you to consider the following. Diabetes is now the 7th largest cause of death in our nation. If current trends are not reversed, 1 in 3 children born after 2000 and 1 in 2 African American or Hispanic children are expected to develop type 2 diabetes during their lifetime. 1 in 2. Obesity and diabetes are costing the state billions every year in hospitalization and Medicare costs. And that's not just insulin and syringes, it's knee and hip replacements, it's heart transplants, liver transplants. In fact, one estimate has it that 75% of every healthcare dollar goes to maintenance or treatment of chronic metabolic disease. Type 2 diabetes used to be called adult onset diabetes. In fact, in 1980, there were no reported type 2 diabetes cases amongst adolescents. But now, 30 years later, there were nearly 58,000 in 2010. Doctors are reporting strokes in 8-year-olds, heart attacks in 10-year-olds, and 30-year-olds on dialysis for kidney failure. And yet type 2 diabetes is a preventable disease. Now, once you have it, that's another story. It's not just about blood sugars being out of whack. It carries with it many commonly occurring complications that combine to lower both quality of life and life expectancy. These include hypoglycemia, hypertension, heightened death rates from cardiovascular disease, higher risk of heart attack and stroke, blindness and eye problems, kidney disease, and amputations. In 2010 alone, about 73,000 non-traumatic lower limb amputations were performed in adults aged 20 years or older with diagnosed diabetes. Today, the overwhelming view of those who study this issue is that the single most significant cause of obesity and diabetes is overconsumption of sugar in any of its many forms. And since 1977, Americans have doubled their intake of sugar. Liquid sugar is a particular problem because of how it is metabolized by the body. And so I'm here to present AB 1357, a bill designed to create a fund and a funding source that will provide a significant source of revenue to educate and provide better nutritional outcomes for young people. Currently, California is falling embarrassingly short. We spend the least on diabetes prevention of any state in the union. There is no state funding for diabetes prevention, and what little funding we do use is provided through grants from the federal government. A comprehensive multi-departmental strategy is needed to combat this epidemic, and AB 1357 creates this strategy. Through funding obtained by a health impact fee on sugar-sweetened beverages, the largest source of sugar in the American diet, the state will be able to distribute funding to programs that seek to fight childhood obesity and diabetes, to improve participation in physical activity, to promote access to healthy fruits and vegetables for our children, and to fund oral health programs. Simply put, the monies collected through the fee will go directly back into the community to address the health impacts of overconsumption of sugar, with a heavy priority given to prevention. When this bill becomes law, children and their parents, and particularly those in disadvantaged communities, will have new access to information about healthy nutrition and making good choices. Advertisements and cheap pricing actively encourage our youth to consume the wrong things. In fact, 41% of children aged 2 to 11 years and 62% of adolescents ages 12 to 17 years in California drink at least one sugar-sweetened beverage every day. Doesn't sound like a big deal, but that's the equivalent of 39 grams or 9 1/3 teaspoons of sugar. Maybe that still doesn't sound like a big deal. But that, for women, is beyond the total recommended intake, which is 25 grams and 6 teaspoons on a daily basis. And it's close to the total maximum, which I believe is 38 grams for males. Science has shown us that drinking sugar-sweetened beverages daily for only 2 weeks leads to an increase in cholesterol and triglyceride levels by 20%. And after 6 months of daily consumptions, fatty deposits in the liver increase by 150%, putting a person firmly on their way to fatty liver disease, metabolic syndrome, and diabetes. The problem is very few people know this and understand this. The only other legal product that has such negative health consequences accompanied by widespread consumption is tobacco. The healthcare epidemic caused by cigarettes has been largely abated due to our intervention, the people's intervention. While our strategy will be different, the need for intervention is no less when it comes to our epidemic of obesity and diabetes, and therefore I ask for your aye vote on this important measure. And I'd like to introduce my two witnesses, Dr. Dean Schillinger and Dr. Laura Schmidt. Thank you.
Thank you. My name is Dean Schillinger. I am a professor of medicine at the University of California in San Francisco and a primary care doctor at San Francisco General Hospital. I also co-run the Center for Diabetes Research at the University of California, San Francisco, funded by the National Institutes of Health. And I recently completed a 5-year term serving as the chief of the Diabetes Prevention and Control Program for the state of California. But I'm here today. I took a vacation day to come here because of my personal and professional obligation to my patients, to my community, and to our state with respect to this public health crisis. I started out my career in 1991, 25 years ago, at San Francisco General Hospital during the peak of the AIDS epidemic. On any given day when I was working in the hospital, we admitted patients for pneumonia or heart disease, what have you. And at that time, 1 out of every 2 patients that we admitted was a young man with AIDS. We were overwhelmed by this epidemic in the early 90s, and the public health community, civic community, and legislators in the city and county of San Francisco got together, and through bold action, we were able to develop very robust initiatives such that at this time today on Ward 5A, which is the AIDS ward at San Francisco General Hospital, there is not a single patient with AIDS. Unfortunately, that AIDS ward now is populated almost exclusively by patients with type 2 diabetes. So within the course of half of my career, 20, 25 years, we've seen us go from one epidemic involving young people now to another epidemic that is also involving young people. And we're talking about young people who are getting amputations, for example. In the 10 years of the Iraq-Afghanistan war, 1,500 American soldiers lost their limbs. In that same 10-year period of time in California, 130,000 Californians lost their limbs to diabetes. That's the scale of this epidemic in California. In my clinic, since I'm a primary care doctor, I see patients in clinic. When I started out, about 1 in 6 of my patients had type 2 diabetes. Now 1 in 2 have diabetes. And among the 50% who don't have diabetes, about half of them have pre-diabetes, which is the condition in which you have a high blood sugar, you don't quite have diabetes yet, but you're about to get diabetes. So my clinic has virtually become a diabetes clinic, and I'm not a diabetes doctor. This disease has moved from a disease that has affected our grandparents to a disease of children. 15 years ago, 1 in 11 children had either type 1 diabetes or pre-diabetes, that condition I talked to you before. Now, it's 1 in 4 children in California have pre-diabetes or diabetes. The children with pre-diabetes will get type 2 diabetes within 10 or 15 years. So 1 in 4 teenagers have pre-diabetes in California. Type 2 diabetes, adult onset diabetes, now is the dominant form of diabetes in children. It used to be type 1, right, juvenile onset diabetes, those kids you would see in school injecting themselves. Now, 3/4 of the kids with diabetes in California have type 2 or grandmother's disease. We have been asleep at the wheel in California. It's now well past time for us to aggressively attack this maiming, blinding, and often fatal disease. Yet it's preventable. If we can pull out all the tricks we have in the public health hat and the civic hat and the legislative hat, we can do something. It starts with you and this bill. You can save thousands of young lives by passing this bill. And I think if you can save thousands of lives in one day, that's a pretty good day at the office. So thanks a lot.
I'm Laura Schmidt. I'm a professor in the School of Medicine at UCSF. I just spent the last few years of my life with a team of 12 scientists at UCSF reviewing the exhaustive literature on sugar and health. And so I want to speak to you a little bit about the science that I know, and I'm honored to be here. So the latest medical evidence supports this legislation. We used to think that sugary drinks just made you fat. Now we know they also make us sick. These products play a unique causal role in type 2 diabetes and in non-alcoholic fatty liver disease. They have little nutritional value and no fiber to slow transit time through the gut. They thus bombard the pancreas and the liver with heavy doses of added sugar. Blood sugar spikes up and down over time, leading to insulin resistance and eventually diabetes. These are well-documented biological mechanisms not in dispute among neutral scientists. I urge you to consider the source when you listen to the scientists, because many have conflicts of interest. Studies by industry-funded scientists are 5 times more likely to demonstrate that sugary drinks have no role to play in weight gain. I'm a scientist with no conflicts of interest, and I can assure you that there is strong evidence that these products play a unique causal role in sickening our children, especially our children of color. I want to just very briefly give you a little, I looked at some of the materials from the opposition, and I wanted to share with you some of my impressions. I think they're good examples of how the science on sugar and health gets manipulated. Since my time is short, I'll just give you one example. Here, the opposition is citing a prestigious paper in the medical journal JAMA, in which myself and others have published articles on this issue. And the opposition claims that rates of type 2 diabetes, according to this article, in kids are lower than 1%. So I went on to PubMed and I looked at this article because that sounded kind of surprising to me. And what I found was that this study focuses on the growing epidemic of type 2 diabetes in kids and shows that children born in the year 2000 have a 32.8%, not 1% lifetime risk of acquiring the disease, and that by kids born in 2050 will have a 165% greater chance of having the disease. So I just want to share with you the importance of neutral scientific information, and I hope that I can always serve, and UCSF will always serve you as a resource for providing you with the latest science in an objective way. Thank you.
Chairman Buonta, members of the committee.
Just to let you know, you have 30 seconds left.
Okay. We're really proud to co-sponsor this bill that we have the California Rural Indian Health Board, Asian Pacific Partners for Empowerment and Leadership, Council of Black Nurses, and Latino Coalition for a Healthy California all coming to you with the urgency of this bill. We're tired of burying our family members. We need your leadership to help us move forward on this. Thank you.
Thank you. Additional witnesses in support, please state just your name and position.
Mark LeBeau, Executive Director, California Rural Indian Health Board, in support of the bill.
Thank you.
Brianna Pittman with the California Dental Association come on as co-sponsors of the bill because of the strong link between dental decay and sugar-sweetened beverages. Urge your aye vote. Thank you.
Callie Hampton, on behalf of the American Heart and American Stroke Association, proud co-sponsor of this measure. We urge your support. Thank you.
Thank you. Additional witnesses in support. Just your name, organization, and position, please.
Mel Osagai with the Los Angeles Urban League. We think this is a crisis that needs to be addressed immediately. We urge your aye vote.
Kat DeBerg with the Health Officers Association of California, in support.
Betsy Armstrong with the County Health Executives Association, in strong support.
Sandra Poole with the California Black Health Network, in strong support.
Sarah DeGio with the California Pan-Ethnic Health Network, in support.
Sawait Sium on behalf of Health Access California, in support.
Heather Jacobs, 2016 Chair of the DCC Diabetes Coalition, in favor of this bill. Thank you.
Justin Rauza with Roots of Change, also a bill co-sponsor, also in support.
Rebecca De La Rosa on behalf of the Latino Health Alliance, in support.
Genoveva Islas with Cultiva la Salud, in strong support.
Alfredo Medina here on behalf of Ultimate Health Services, also here in support.
Kathy Mossberg representing the Public Health Institute, co-sponsor and support.
James Earl Hall with the 100 Black Men of Sacramento, Chairman of the Health and Wellness Committee, strong support.
Chair and member Sean South on behalf of the California Primary Care Association, we are a sponsor of this bill and urge your aye vote.
Dr. Lynn Silver, pediatrician and director of California Project Lean, strongly urging your support.
Mr. Chair, Member Stephanie Roberson on behalf of the California Nurses Association. It's also our lobby day. We have 300 nurses here in support, but I only brought 3, so in support.
Lori Clemens, California Nurses Association, in strong support.
Jennifer Wheeler, Desert Regional Medical Center, RN. Thank you.
Jill Calvert, Desert Regional Medical Center, RN, in strong support.
Brendan Tuig on behalf of the California Center for Public Health Advocacy, in support.
Michael Radigan on behalf of the Board of Supervisors, Santa Clara County, in support.
Chris Lipp Twombly with the California State Alliance of YMCAs. We have no position on the bill, but we are committed to the effort to reduce the type 2 diabetes crisis in California, and we have grave concerns about the unique harms of liquid sugar consumption.
Kimberly Chen on behalf of the Having Our Say Coalition, in support.
Beth Capel on behalf of AFSCME, in support.
Thank you. See no additional witnesses in support, witnesses in opposition. Can we please make some space for them at the desk? As a reminder, you have 8 minutes to split up as you see fit.
Good afternoon, Mr. Chairman, members of the committee. Thank you for the opportunity to speak with you today. My name is Lisa Caddick. I am a registered dietitian with 25 years of experience in food and nutrition policy. I've advised federal, state, and local government agencies, food and ag companies, trade associations, and health professional organizations. I think we can all agree that obesity and related health problems are very serious and complex issues, but it's overly simplistic, not to mention misleading, to single out sugar-sweetened beverages as the driving cause of type 2 diabetes. I want to point out a recent study that was funded by the Robert Wood Johnson Foundation and the National Institutes of Health showed that large increases in sugar in soft drink taxes are unlikely to reduce total caloric intake. In fact, the research found that on a national level, an increase in taxes on sugary drinks actually resulted in adults consuming over 27 calories or adding 27 or more calories to their daily intake by substituting soda with something else, often foods that were higher in fat or sodium. In fact, one of the lead researchers on this study said that consumers can simply substitute an untaxed high-calorie food for a taxed one. And as we know, reducing calories really is one of the many ways to promote health and reduce nutrition-related chronic diseases. So if your goal today is to implement or to address obesity and diabetes-related solutions, I think we need to consider some important facts that are missing from this conversation. The intake of added sugars from sugar-sweetened beverages has dropped by 37% from 2000 to 2008, but the rates of overweight and obesity during that same time period have increased from 64 to almost 69%. I think we confuse consumers and we oversimplify a complex disease by stating that sugar-sweetened beverages are the sole cause of obesity. Obesity experts, nutrition educators will tell you managing weight is about energy balance, calories in and calories out. We know that sugar intake from sugar-sweetened beverage consumption has declined in the past 10 years, so why haven't diabetes and obesity rates also declined? Identifying a comprehensive approach of prevention that involves the multifactorial components to these serious health problems is needed, not finding a scapegoat and not creating headlines. Turning to another big contributor to this issue is physical activity. I want to point out that the CDC reports that more than 60% of American adults are not regularly active. I haven't heard one person mention this yet today. 60%. And 25% of the adult population is not active at all. Today's workers are burning an average of 120 to 100 and fewer calories each day on their jobs. We know that a lot of our jobs now are sedentary, compared to that in the 1960s. Computer modeling of government data shows that a significant portion of the increase in obesity rates can be accounted for by our decrease in physical activity during our work. Researchers at the Mayo Clinic also report that the levels of prolonged and consistent sitting in the United States can result in an increased risk of obesity, high blood pressure, and cardiovascular disease, amongst others. So there's no evidence that a $3 billion tax on sweetened beverages, some as low as 18 calories per serving, would improve the rates of obesity and diabetes in California. Thank you for your time.